Abdominal hystrectomy, William's Gynecology, surgical steps. Number 1. Anesthesia and the patient positioning. It is typically performed under general or regional anesthesia. Regarding position, the patient is often supine. However, if concomitant vaginal procedure or cystoscopy are planned, the patient is placed in low lithotomy position. After anesthesia, hair clipping in the path of planned incision if required, Foley catheter is inserted, abdominal and vaginal preparations are completed. Number 2. Abdominal entry. Either transverse or vertical incision may be used for hysterectomy. Exposure. After entry into the abdomen, a self-retaining retractor is placed. The pelvis and the abdomen are visually and manually explored. The bowel is bagged from the operating field. The uterus is grasped and elevated from the pelvis. Curved clamps are placed immediately lateral to each uterine cornu to permit uterine manipulation. Division of the round ligament at its midpoint. This provides entry into the retroperitoneal space for ureter identification and access to the uterine artery and the cardinal ligaments. The round ligament is grasped with tissue forceps and elevated. A transfixing stitch using zero delayed absorbable suture is placed about 1 cm lateral to the planned division site. The first bite passes through avascular site of the mesoteres under the round ligament, while the transfixing bite bursts the round ligament, medial to the first bite. A second simple stitch is placed 1 cm medial to the first, and again through an avascular site in the mesoteres and under the round ligament. After that, the round ligament is divided between the two sutures, and the incision line is directed deeply about 1 or 2 cm of the broad ligament. Step 5. Anterior broad ligament leaf. The round ligament suture are placed on tension, and the incision is made in the anterior leaf of the broad ligament. Scissors are introduced between the anterior leaf and the underlying loose connective tissue. Scissor tips are directed upwards to be seen through the peritoneum as they advance. Gentle opening and closing of the scissor blade during advancement separates the peritoneum from the underlying connective tissue and uterine vessels. Now the elevated anterior leaf is then incised either sharply or with the use of electrosurgery tip. Continue incision to the level of the vesico-uterine fold. To further open the retroperitoneal space, the peritoneum lying between the round ligament and the infundibulopelvic ligament is grasped with a smooth forceps. This peritoneum is then incised lateral and parallel to the infundibulopelvic ligament. The incision is extended kephalat towards the pelvic side wall and to approximately the level of the pelvic brim. Step number 6. Ureter identification. The ureter is identified within the pararectal space, close to the pelvic brim and at the common iliac artery bifurcation. Then it can be traced deeper into the pelvis by localized blunt retroperitoneal dissection. Step number 7. Posterior leaf of the broad ligament. With direct visualization of the ureter, the posterior leaf is incised to create a window. If ovarian preservation is planned, this window is made under the utero-ovarian ligament and near to the uterine body. However, if oophorectomy is planned, the posterior leaf is incised parallel to the infundibulopelvic ligament. Step number 8. Adenexectomy. If removal of the ovary is planned, then the fallopian tube and the ovary are grasped with a babcock or other atraumatic clamp and elevated medially to place the infundibulopelvic ligament on mild tension. 2 clamps are placed around the infundibulopelvic ligament through the window created in the posterior leaf of the broad ligament. The ligament is sharply transected between the 2 clamps. A free tie of zero delayed absorbable suture is placed around the lateral clamp to ligate the ovarian vessels. As the knot of this suture is secured, the clamp is quickly opened and closed. Then a transfixing stitch is then sutured below the clamp. Step number 9. Ovarian conservation. If ovarian preservation is planned, salpingectomy alone can be completed. The mesosalpinx is serially clamped, cut, and ligated. Each clamp incorporates about 2 cm of mesosalpinx, and the resection progresses from the fimbria to its union with the uterus. Then a clamp is made around the uteroovarian ligament through the window made in the posterior leaf of the brood ligaments. The uteroovarian ligament is then incised between the two clamps. After that, the uteroovarian ligament is ligated in the same way as the infundibulopelvic ligament. I mean, with a free tie followed by a transfixing suture. Step number 10. Bladder flap. The previous steps are completed bilaterally. Then the vesico-uterine space is opened, and the bladder is moved caudal and away from the cervix. Several techniques may be used to perform this step. Sharp dissection is preferred for patients with prior caesarean deliveries, who may have scarring between the bladder and the cervix. Alternative methods include gentle, blunt pressure from fingers or a sponge stick. This pressure is directed caudal, beneath the bladder and against the cervix. Dissection in the midline minimizes laceration of vessels that course within the vesico-cervical ligaments, known as bladder pillars. Once the correct plane is entered, the pearly white cervix and the anterior vaginal wall are clearly differentiated from the reddish bladder fibers. The bladder is ideally dissected off the anterior vaginal wall at least 1 to 2 cm below the lower margin of the cervix. Step number 11. Uterine arteries. The uterine vessels are identified laterally along the uterus. Some peritoneum and loose areolar tissue still surround these vessels. Incising and removing such tissue from around the vessel is termed skeletonization. After skeletonization, the uterine vessels are secured by a curved Zeppelin clamp at the level of uterine isthmus. The clamp tips are placed horizontal across the vertical uterine vessels. A Kelly clamp is placed medial and vertical to the first clamp and hugs the lateral uterus to prevent bleeding from the severed vessels. Then the tissue between the clamps is cut. A simple stitch of delayed absorbable suture is placed below the Zeppelin clamp tip. As the knot is secured, the Zeppelin clamp is slowly opened and removed, while the Kelly clamp remains to prevent bleeding from the severed vessel. A large pedicle may be tied twice to ensure ligation. Cardinal and uterosacral ligament transection. These ligaments are present lateral to the uterus and inferior to the uterine vessels. A straight clamp is positioned across the cardinal ligament, adjacent to the cervix, and medial to the uterine artery pedicle. A scalpel then transects the portion of the cardinal ligaments medial to the clamp. Ideally, the surgeon cuts close to the uterus. Then a transfixing stitch is placed below the clamp, and the clamp is removed as the knot is tied. Depending on the ligament length, the previous step may be repeated several times. The suture tail of the uterosacral ligaments may be left long for identification to allow later incorporation of these pedicles into the vaginal cuff closure. Step 14. Vaginal transection. The surgeon hand palpates through the anterior and posterior vaginal walls to identify the most inferior level of the cervix. Then a curved clamp is placed across the anterior and posterior vaginal wall, just below the cervix on one side. This is repeated on the other side, and the tips often meet in the midline. The vaginal tissue above the level of this clamp is then transected. This frees the uterus from the pelvis. Transfixing sutures are placed below the clamps, and the clamps are then removed. And a delayed absorbable suture may be placed to suspend the vaginal apex to the uterosacral ligament pedicle on either side.